Good morning, students. Today we are going to discuss some common pediatric surgical problems. So first and foremost problem is congenital diaphragmatic hernia. In short, it is known as CDH. So CDH is defined as herniation of abdominal contents into the chest through a congenital defect in the diaphragm. The etiology and embryology is it is the failure of fusion of the septum transverse sound with the dorsolateral diaphragmatic process, that is the pleuroperitoneal membrane. So the types of diaphragmatic hernias are the most common is posterior defect, that is called as Bogdalek hernia, because it occurs to the foramen of Bogdalek and it amounts for 90% of the defect. Then second one is the anterior or the Morgagni hernia, and third is the eventration of diaphragm. Eventration is just the weakness; it is the neuromuscular weakness of the diaphragm. So this is a schematic illustration of left-sided congenital diaphragmatic hernia, which is showing abdominal viscous, most of the abdominal viscous into the pleural cavity. The pathophysiology is there is a ipsilateral lung hypoplasia because of mass effect. There is a contralateral lung compression because of the volume occupation by the abdominal contents. There is pulmonary hypertension in right to left shunting. That is a persistent fetal circulation. And sometimes there is ischemia of the herniated bowel. Diagnosis, how will you diagnose? It is usually diagnosed antenatally. The telltale features may be maternal hydramnios, and this is easily picked up on ultrasound. And after birth, how will you diagnose? In severe cases, there is immediate respiratory distress, there is cyanosis, there is gasping, air entry will be absent on the affected side, and there is muffling and shifting of the heart sounds, and the abdomen will be scaphoid. In mild cases, there can be a delayed diagnosis. They may present with recurrent chest infection and accidental auscultation of the bowel in the chest. So what investigations we perform? We perform the commonest investigation is a simple X-ray chest. Then you do arterial blood gases, echocardiography, ultrasound, and rarely CT may be required to confirm the diagnosis. This is a classical case of diaphragmatic hernia. You can see the left chest being occupied by bowel loops. The heart has been shifted to the other side. Sometimes you can do a dye study. See a dye study showing the bowel loops in the chest, and some part of the dye is going into the abdominal cavity because some of the part of the viscous may be in the abdominal cavity. Differential diagnosis. So you have to differentiate them from other causes of respiratory distress, which are common causes which occur commonly in a neonate. How will you manage such a case? The preoperative management includes insertion of a nasogastric tube. So you have to deflate the stomach. Then if the patient is in a severe respiratory distress, you have to do an endotracheal intubation and you have to ventilate the patient. Then maintain the patients on IV fluids, maintain the temperature, and obviously this is done in an ICU setup. Now the surgical part is operation will be on the diaphragmatic hernia is on the left side. Then you have to go for an abdominal approach. The incision is a standard subcostal incision. You have to reduce the contents and repair the diaphragm. The diaphragm can be repaired in 2 layers, or that is called as double busting. See, the contents have been reduced. You can see the defect very well. Then the contents have been reduced, and the defect has been closed. Post of care is very important. You have to continue the patient on the ventilator support. Esophageal atresia and TO fistula is the next common cause. Definition of esophageal atresia is there is an interruption in the discontinuity or discontinuity in the continuity of a esophagus. TO fistula is an abnormal communication of the esophagus, lower end of the esophagus or the upper end of the esophagus. It opens into the trachea. Esophageal atresia may present with or without a tracheoesophageal fistula. And TEF may present with or without esophageal atresia also. So the etiology is there is a defect or incomplete partitioning of the primitive foregut. So these are the common types of esophageal atresia. 5 types have been described in the literature. The commonest is the third variety, that amounts to the 85% of the cases, in which the upper pouch is blind and the lower pouch is ending into the trachea. The next common is the type 1, which is a pure esophageal atresia. There is no communication with the trachea. In these cases, the esophageal length is much shorter as compared to a teo fistula. The second variety is amounts to 2%, and there is a fistula to the upper pouch. The lower pouch is ending blindly. Then fourth one is a fistula where there is a communication with the upper pouch as well as lower pouch. And the fifth one is the H variety of teo fistula, which is very difficult to diagnose. So pathophysiology is there is failure of swallowing, there is dehydration, there is hypoglycemia, and there are chances of aspiration pneumonia. There is chemical pneumonitis because all the saliva that is getting accumulated in the upper pouch goes to the trachea. And in cases of there is in cases where distal fistula, there is regurgitation of the acids into the stomach, which result in severe pneumonia. Diagnosis, you can do antenatally also. You can have some signs antenatally. The maternal history of polyhydramnios may be there. There is excessive salivation, drooling, coughing, choking, cyanosis during the first oral feeding. So you get a idea during the first feed itself. Then there are patient may present with chemical or aspiration pneumonitis. And very important sign is there is inability to pass an nasogastric tube into the stomach. And the confirmation is on X-ray, if you pass a tube, it gets coiled in the upper pouch. So there will be a coiling of the Ryle's tube or another tube, whatever you are using in the upper mediastinum. And you have to look for the gas in the lower abdomen also to differentiate whether there is a pure esophageal atresia or type 3 esophageal atresia. Sometimes we can do a contrast study, although it is not used nowadays. And tracheostomy fistula, with or without atresia, may present with rectal anomalies also, such as anal atresia or rectal atresia. You should always search for a vectoral anomaly. Vectoral anomalies are associated with vertebral anomalies, anorectal, cardiac, tracheal, esophageal, renal anomalies, and sometimes there are limb anomalies. These are present in as high as 50% of the cases. So other investigations may also be done. For example, you have to do a X-ray and you have to do a echo, because echo prognostication is very important. If there are cardiac anomalies, you have to tell the patient relatives accordingly. Management. The preoperative management includes definitely the child has to kept nil orally. You have to do a continuous upper pouch suction in an ICU admission, which a very well trained staff. You should place the patient in a supine and an elevated 30 to 40 degree position. In an incubator, you have to start the patient on oxygen. Sometimes endotracheal intubation may be done if the patient is, if there is a respiratory distress. IV fluids and IV antibiotics should be instituted, and meanwhile investigations must be done to exclude vectal anomalies. And usually we require an urgent surgical repair once the complete preparation has been done. Regarding the operation, low risk infants should get primary repair. High risk babies we do gastrostomies, which is a temporizing procedure. Usually we operate through the right thoracotomy through fourth intercostal space. Operation includes TEF ligation, then transaction and restoration with end-to-end anastomosis over a Ryle's tube. And ICT is inserted in the right pleural space to drain the pleural cavity. On fourth or in fifth or seventh post-operative period, we usually do a dye study that is called esophagogram. And if there is a no leak, then you can remove the Ryle's tube and start the patient on the feeding. Complications can be divided into early complications, which includes anastomotic leak, recurrent teo fistula, or tracheomalacia. And late complications include anastomotic stricture, which occurs in as high as 25% of the cases. Reflux, these patients develop in 50% of the cases. And motility disorders are usually present in all the cases. Third important topic is congenital hypertrophic pyloric stenosis. Now it is not known as congenital, it is because it has been proved that it is not a congenital anomaly, it is a acquired anomaly. So it is called as a IHPS, infantile hypertrophic pyloric stenosis. It is a very common disorder between the age of 2 to 8 weeks. Mostly affected patients are the male patients. So pathophysiology is there is muscular hypertrophy of all the layers of the pylorus, most significant in the circular layers, causing pyloric stenosis, and there is gradual gastric outlet obstruction. The patient presents with repeated vomiting, then there is a loss of weight, there is increased peristalsis. Diagnosis is relatively straightforward. Symptoms, the onset of symptoms is 2 to 3 weeks after birth. Rarely it is congenital. Persistent projectile vomiting, which is non-bilious, is pathognomic of pyloric stenosis, and the baby is hungry immediately. That is, they feed vigorously and then vomit again, and they will be hungry again. Signs are general signs includes dehydration, weight loss. There is oliguria. There is tinge of jaundice. And if you do a clinical examination, there will be distension of epigastrium, then visible gastric peristalsis will be there, and palpation of a pyloric tumor or pyloric olive, that is pathognomic of pyloric stenosis. Investigations includes the gold standard is ultrasound, which is diagnosing most of the cases. In this, you have to see for the length of the pylorus, the thickness of the pyloric muscle, and the lumen. Previously, we used to do barium or gastrographic dye study when there is a difficulty in diagnosis. So the findings will be this: there will be a dilated stoma, there will be strong gastric peristaltic waves, there is elongated and narrow pyloric canal that is called a string sign, and the gastric emptying will be delayed. Laboratory investigations includes serum sodium, potassium, calcium, and chloride, all of which are expected to be low. So there is hypochloremic, hypokalemic metabolic alkalosis, and there is sometimes indirect hyperbilirubinemia. So this is a ultrasound picture. You can see the thickened pyloric muscle. More than 4 millimeter is usually sufficient to diagnose. This is a rare barium mill done, which is showing a elongated pylorus with there is no emptying of the stomach seen on this film. This is another view of the same barium. See, this is known as string sign. There is a very thin barium which is getting passed through the pyloric canal. So this is pathognomic of pyloric stenosis. Management includes preoperative preparation, which is very important. You have to maintain the hydration of the patient by IV fluids, then correction of electrolytes and metabolic alkalosis is very important before taking the patient to the OT. The standard is operation is threaded Ramstead pyloromyotomy, which is done through transverse right upper abdominal incision. The intraoperative finding usually includes a olive shade mass, which is 2 to 3 centimeters in length, pale in color, located at the pylorus, and it feels like cartilage. What you do is you have to do incise on the anterolateral aspect, and then you have to dilate the muscles with the help of there is a special instrument, or you can use a blunt artery faucet. Now, during this procedure, you have to avoid perforating the gastric mucosa. The commonest side of breaching the mucosa is towards the duodenal side. Usually, there is no danger on the stomach side, but on the duodenal side, you can breach the mucosa. This is the schematic representation of the pylorus. You can see after giving the incision, you can see the bulge of the mucosa. These are some of the photographs of the pylorus. This is showing completed pyloromyotomy. Post-operatively, infants are usually maintained on IV fluids for 12 to 14 hours. Then gradually you resume with oral feeding usually on the second day, and the patients are usually discharged within 2 to 3 days. Intussusception is a very common acute abdominal condition which is seen in a pediatric age group. So what is intussusception? Intussusception is there is an invagination or telescoping of a proximal segment of bowel, that is called an intussusceptum, into the lumen of a distal segment, that is called intussuscipiens. So usually a small caliber of a bowel like a jejunum or a ileum, it protrudes into the or telescopes into the colon, which is of larger caliber. It is the second most common cause of acute abdominal pain in children following appendicitis, and commonly seen between 3 months to 2 years of age and peaking at around 5 to 7 months. And this has something to do with the weaning process. Etiology includes mostly they are idiopathic cases, and most of them are ileocolic. In less than 10% of the cases, you can find a lead point. Most common is a Michel's diverticulum. Other possibilities are includes the pathologies like hemangiomas, polyps. There could be lymphomas, some cysts. Appendix is also labeled as a cause of recurrent appendicitis, recurrent interception. Intestinal neoplasm rarely. Some mucosal hemorrhages are associated with alloxanly purpura can cause interception. Sometimes, rarely, foreign bodies, ectopic pancreas or gastric tissue, and intestinal duplication cysts. Pathophysiology of interception goes. There is invagination. The agglutinated segment is carried distally by peristalsis. Mesentery and vessels become involved with the interluminal loop and they are squeezed within the engulfing segment, which causes initially venous congestion. If untreated, it can lead to hemorrhage and gangrene. So types of interception includes they are enteroenteric, enterocolic, or colocolic. Most common is enterocolic. The diagnosis is a child presenting with a crampy abdominal pain, otherwise in a healthy child. The child usually draws up his leg during the pain. Then after some time, the child becomes lethargic. Then the vomiting may start. Initially maybe non-bilious. Then if untreated, it becomes bilious. Constipation, although frequent bowel movements may occur with the onset of pain. Red currant jelly stools. They are pathognomic of intussusception. They are dark blood clots which are mixed with mucus and a presence of an abdominal sign, abdominal mass. That is called a sign the dance or abdominal lump. How will you diagnose that condition? So you do a simple X-ray abdomen, although it is not very helpful and can be negative in early stages. Then most important is diagnosis for the diagnosis of interception is ultrasound. So you have to evaluate the risk of perforation before. If you are planning an enema treatment, the X-ray will help you if there is already a perforation and diagnosing other diseases like volvulus. Radiological signs of interception includes these are all ultrasound signs are target sign. You will see a target sign on an ultrasound. Crescent sign is seen on a dye study. And absent liver age, also called as absence of subhepatic angle. Then there are features of bowel obstruction, and mostly you get a normal X-ray early. This is a plain X-ray. This is not very pathognomic. Or sometimes you see a target-like picture. So target sign is created by gas which is trapped between the two layers of the intestinal wall. But this is more clearly seen on a ultrasound picture. Sometimes very rarely you can see on a plain X-ray abdomen. Now this is a picture of a child with interception with which has developed a small bowel obstruction. There are multiple dilated bowel loops. You can see a mucosal pattern that is the concertina effect. See another picture of multiple air fluid levels. This usually occurs in a late stage. So you have to keep in mind that plain abdominal films cannot be used to rule out interception. Now ultrasound. Ultrasound is the gold standard to diagnose interception and prevent unnecessary enemas. It is highly sensitive and specific. There is no radiation exposure and it excludes other pathology also. Findings are a target sign or a sandwich sign. Target sign is seen on a transverse view and on a longitudinal view you will see a sandwich sign. So this is a target sign. Another picture of a target sign. This is called sandwich sign. The center part is the intersusceptum and the peripheral part is intersusceptions. This is a claw sign that is seen on a dye study. You can use a barium or nowadays we use a gastography if really it is required. Sometimes you have to do a CT scan also. You can see a target sign in CT scan also. And you can see a sausage shaped mass on a CT scan. Now the management. So initially you have to resuscitate the patient and you to stabilize the patient for surgery. You have to keep the child nil orally, pass a nasogastric tube. You start the baby on IV fluids, broad spectrum and antibiotics, and if required, if there is a heavy loss, already blood loss, then you have to transfuse the patient. Then in early stages, we can try enemas, parectal enemas. When there is when there is a initial stage, you can try a hydrostatic flexion by air enema, contrast enema. More importantly and more commonly and more safe is warm saline. Even if there is a perforation, there will be less chances of complication. Now, types of enemas are, as already said, pneumatic, that is, we use air, hydrostatic reaction, that is the fluid enema, and the barium enema, that is a fluid with a contrast. So these are the pictures with the contrast. You can see initial the claw sign, then gradually there is reduction, progression, and there is complete reduction in the third picture. Surgery. So if any need of surgery required, then you have to export the patient through a transverse supraumbilical incision. If there are viable intestines, then reduce by milking. And usually we do appendectomy, or if there is associated mucous diverticulum, you have to do a diverticulectomy. If there are gangrenous loops, resection of the affected segment with primary anastomosis has to be done. Primary allostomy or mucous fistula formation is really needed. So this is a clinical photograph. You can see a small bowel invaginated into the colon. These are another pictures, and this is a post-op picture in which there is already gangrene. So the bowel has been resected, and end-to-end anastomosis of ileocolic segment has been done on a healthy bowel. Now, fifth entirety is a Hashimoto disease. This is a typically seen in pediatric age group only. It is a neurogenic form of intestinal obstruction. There are absence of ganglion cells in the meningic and submucosal plexuses. So it results in failure in relaxation of the internal anal sphincter and affected bowel. Upstream bowel becomes dilated secondary to distal obstruction because they have to work against more resistance. Pathogenesis includes there is failure of neural crest cell to migrate caudally. So aganglionosis begins at the anorectal line and it is carried forward upwards. 80% cases involve only rectosigmoid area, 10% extend proximal to the sphenic flexure, and 10% involve the entire colon and part of the small bowel, that is total colonic aganglionosis. Rarely involves entire GI tree also. That means from esophagus, stomach, right to the anorectal junction. Presentation usually with severe abdominal distension. 95% they fail to pass meconium in the first 24 hours of life. So usually you get a history of delayed passage of meconium even after 72 hours of birth. Then the child may present with bilious vomiting. On PR examination, there will be a gush of stool and gases because you are passively dilating the aganglionic segment. In older children, they present with constipation, failure to thrive. In 15 to 20% patients with Hashimoto disease, they present with enterocolitis, that is severe explosive diarrhea, fever, dehydration, and distension of abdomen. So this is a neonate with a Hashimoto's disease. You can see abdomen, distended abdomen,